Well, thanks again for having me. What I'm going to talk about, and I'll sort of give you the background in terms of why I'm perhaps giving this talk. But I'll set the stage a little bit. I'll talk about some of the issues. I'll talk about who the stakeholders are, because if you're talking about reimbursement, then who's paying the bill, right? But what I will tell you is that this is not a conversation about CPT codes and things like that. So if you're looking to how you can figure out how to, code better, and that's not really where this is at. This is really a longer-term vision and the strategy and where I think, based on my background, where we need to apply the pressure, so to speak, in order to make this happen. So again, this isn't about CPT coding, and it's not really about traditional value-based care, because as I go through this presentation, I want you to think about, when we talk about value-based care, value for whom? And what I hope you'll see by the time I conclude is that the whole idea of value-based is a little bit misplaced when you really think about it and when you really see who's profiting from this. A little bit more about my background. You heard that I'm the former president for the American College of Lifestyle Medicine. The other thing I want you to take away from this is that I have spent most of my time on the payer side. So I was the chief medical officer for a Blues plan. I've also worked for various vendors in the space, including pharmaceuticals. So don't hold that against me, but what it does allow me to do is it gives me an insider's view of where the dollars are flowing and what the incentives are from all of these various aspects, from a large medical center to an employer, Cummins engine, the diesel engines that might run in your Dodge Ram. 55,000 employees. As an employer, healthcare cost is truly a cost. And so how would they look at that? And we're going to really do a deeper dive on why employers actually are where we should be applying our energy in terms of changing reimbursement for lifestyle medicine down the road. As mentioned, I'm the president for the Blue Zone Wellbeing Institute. I don't know, how many of you are familiar with Blue Zones? So some of you are, but again, these are places around the world where people live to be 100 years old or more, and they don't have the chronic conditions that we have here. Now, when they move to the United States, they adopt our lifestyle, our diet, et cetera, then they start to develop the same kinds of conditions we do. But it's really a nice proving ground in terms of lifestyle, and of course, the reason we need lifestyle medicine is that we don't live in blue zones, if you really think about it. So we have to apply this other level of care on top of this, and you've all day have been hearing, and yesterday, and you'll hear tomorrow, the benefits of lifestyle medicine. But if we all lived in a blue zone, we may not even need to have this conversation. The other thing is that, as I mentioned before, my background is really in reimbursement. I was originally trained as a general surgeon. That's my clinical training. And then I went on to become board certified in preventive medicine and now also lifestyle medicine. But my background in terms of healthcare after about the first 6 or 7 years has really been in the corporate side and on the payer side. That continues. I'm the vice chair for HERO, which is the Health Enhancement Research Organization. It's about 100 large employers that are really looking at research around well-being and health for their populations, as well as benefit design for that. I'm also the most recent board of director trustee for the National Alliance of Healthcare Purchaser Coalitions. These are all of the business coalitions around the country. They roll up to this particular national coalition. So you have the Midwest, you have the Pacific, and the Northeast business coalitions. Again, those are made up of payers, employers, self-funded employers. That's important because the self-funded employer, they design their own benefits. They oftentimes negotiate with their unions. They come up with their own benefits. They decide what benefits they want to provide for their employees, as well as what the costs to their employees will be and what they want to pay for. So that's important. That's the context of this, because that is the strategic area where we need to go to. If you think you're going to do this through CMS and Medicare and Medicaid, that's one avenue, but that's going to take years, and with today's political climate, I'm not really sure how much progress we'll make in the short term at all, if anything. So employers have a reason for this. I'm not going to spend a lot of time on this. You've heard this all day, that lifestyle issues are important. It's driving costs, not just for CMS, but it's driving costs for these employers. I used to work for a CEO, and he would say, Dexter, you know, every year my healthcare costs go up by 10%. And when you're spending $1 billion on healthcare every year, a 10% increase is not novel. And he says, what do I get for it? In fact, my employees are getting less healthy every year, and every year my costs keep going up. What can we do about this? And so that's the context that these employers are looking at this. And of course, oftentimes what they do is they push this onto the employees and higher copays, deductibles, et cetera, et cetera. The other choice they have is to raise the cost of goods. And so one way or the other, we end up paying for it, even with CMS. Taxes, those kinds of things, deficits that we're talking about right now are all related to some of these things. This was like a year or so ago, but again, 19.7% of GDP. That means for every dollar, 20 cents goes to health care, and this continues to increase. I remember when I first started to work for Blue Cross Blue Shield of Michigan, it was around 12%, and everyone says, oh no, it can't go up any higher, but it has. So you can kind of see what's happening there. So then the question is, with all that increase in healthcare costs, who's really benefiting from those increased costs? I don't know how many of you are familiar with Dr. Brecker, Eric Brecker, but if you haven't listened to his videos, it's on YouTube, it's free. It's an excellent source of some of this information. And so he gives an example. I just took this off of his YouTube site. And he says for a patient that has rheumatoid arthritis, where does the money go? And so what you'll see here is that they had a knee replacement. $50,000 goes to the hospital. $78,000 goes to the pharmaceutical company for the drugs. You know, those specialty drugs. And how much goes to the doctor? $600. Since 2015, we've seen an increase in overall healthcare spending go up 52%. The consumer price index has gone up 28%, and physician fees have gone up 29%. So as physicians, we're just barely making it in terms of inflation, but look at overall healthcare costs, and if you look at those other bars, you can see where it's going. It's not coming to us. And so how do we get out in front of that, given the value that we bring to the situation? So we look at all the stakeholders. You look at who's paying for what. We think about, again, value-based care. We can talk about patients. We can talk about employers, government, insurers, pharmaceutical companies, hospitals, and physicians. Who stands to gain? Who stands to lose when we really talk about lifestyle medicine and some of the things? If we were to decrease the rate of cancer by 50%, and you just heard a lecture on cancer that through lifestyle, that's probably something we can do. And even if you just cut it by a third, who benefits from that? Who really benefits from that? So as I go through this, you'll sort of see why I make that last statement, that employers are in a unique position. Again, they control the benefit design. They have ultimate say on how much they want to pay and how they pay it, and if they want to pay for lifestyle medicine. Right now, they don't even understand what it is, so they're not asking for it, but that can change. So who are the big payers? It goes by this little acronym over on the side here, BUCA. The Blues, United, Cigna, Centene, C2 really, Humana, and Aetna. Those 5 companies control the lion's share of the health plan insurance market. The difference between those two charts, one is based on revenue, the other is based on market share. You can see that United Health Group is the leader, and Anthem, now called Elevance, are the leaders in both market share as well as revenue, and you can sort of see where the others fall out. But the top 5 control the majority of the market. So these are the payers. So even if it's on the government side or employers, because employers work through these kinds of organizations. So the employer says, this is the benefit package I've negotiated with the union or whomever. This is what I want you to deliver. They then contract with these plans to deliver that to their employees. The other thing that you need to know about, we talked about pharmaceutical companies, PBMs, pharmaceutical benefit managers, same story. So you have a handful of insurers that control the market. You have a handful of PBMs that also control the market. You can see over here, I don't know if my pointer's working, but you can see, maybe it's not. But you can see here in terms of the percentages, in terms of prescription claims, 6 PBMs handle 95%. So again, small numbers. And then the story thickens. It gets even worse when you look at this slide, that the PBMs and the insurance companies are actually in bed together. So you would think that the insurance companies would be watching over the PBMs so that, they're not just running amok and vice versa. But you can see that United Health Group, they have Optum. They purchased Catamaran a few years ago. You have Anthem and Ingenix and Express Scripts. You have Aetna with CVS, on and on and on. Each of them now has a PBM. Part of the reason they do that is that you have this thing known as the medical loss ratio. Medical loss ratio says that 80 to 85%, depending on what plan you're talking about, of a premium dollar has to go for health care. And the insurer only gets to have that 20% or 15%. But guess what? If you own a PBM, that doesn't factor into the medical loss ratio. So now you can make more profits on the PBM side, and that's exactly what's happening. 3 entities, CVS, Aetna, Cigna Express, and United and Optum control 80% of the PBM market. And I just sort of touched on why a United and a CVS, an Optum, and a Cigna all would want to be bringing this together. Follow the money. And I'm sure many of you know this. If something doesn't make sense, it seems illogical, it's just because you don't understand how the money flows. You follow the money, it makes a lot of sense in terms of what's happening out there. And also why lifestyle medicine is such a hard thing to kind of convince people to do, at least from the payer side. Because you'd think, man, we're saving all this money, why wouldn't anybody go for it, right? Don't the insurance companies want to save money too? Well, we'll see. PBMs are the tail that wags the dog. What you will find is that they're actually making more money on the PBM side of the business than the insurance side of the business. Little known fact.
So they want us to stay sick.
There you go. Follow the money. How do they make money off of empty hospital beds? Do they make money by not selling any drugs? Okay, all right. The 10 largest PBMs, 6 are exclusive to specific insurers. AMA has talked about this. Others have talked about this. This is not a good thing, but this is what's happening. Go on here, and this is, I think, where we talk about these companies generate more revenue and profits than the insurance part of their business. Again, it's the tail wagging the dog. Okay? It's also why you probably heard about this too. Right? There are not enough physicians, so do we let pharmacists have more role in primary care? I don't think this is a good thing. I have nothing against pharmacists, but they're not physicians. They don't know how to diagnose like we do. And what are they going to end up doing? Pushing more drugs. So it fits the model, right? Yeah. So when you have that conversation about why this shouldn't happen, you also need to understand and make sure others understand where the dollars are flowing. So this is a nice vertical because you can see the insurer, you can see the PBM, and then there's the specialty pharmacy, which goes on the medical side of the ledger, but is the biggest piece, fastest growing. So for example, specialty drugs, the Humiras, the Enbrels, those kinds of drugs, and a lot of them you see advertised on the nightly news. I used to work for Amgen, makes these kinds of drugs, and I was involved with their strategy. At Cummins, again, a self-funded employer, we had 55,000 employees. 1/3 of my pharmacy costs I spent on 609 at the time employees that were on specialty drugs. That tells you how big that market is. And if I could just move 100 folks off of those specialty drugs, I could save a huge amount of money. Forget ER visits and some of that stuff that we just sweat over. Just get a few people off of, a $100,000 drug. That's a huge win. And by the way, if you get them off that drug, they're probably healthier because you've done some other things for that individual as well. So anyway, the specialty pharmacy is part of that, big business. And then look, who else are they trying to buy? Physicians, right? Did you know that United has more physicians that work for them than hospitals? There's a reason for that as well. And you know what that game is. That really has to do with Medicare Advantage, because if you read the top part of there, insurers can cover sicker policyholders, receive higher payments. They get us on an algorithm. They have the physician code more. They get more payments, more money. That's the game there, and that's why they're acquiring. Venture capitalists are now acquiring, practices because there's money to be made there. But again, as you looked at the bars I showed you earlier, we're not the one. We benefit a little bit, but we're not benefiting like the big guys. And there is a way where we all can benefit by doing the right thing, but we have to change some of these policies and how we go about this. And of course, they're laughing all the way to the bank. I don't know if you saw the CEO salaries of some of these Medicaid programs. Medicaid, that's supposed to be for poor folk, and these folks are making like $30-some-odd million a year as the CEO. Yeah. So anyway, if you're looking to the insurance companies to figure out how to save money and how to promote lifestyle medicine, you're looking in the wrong place. You got to look at employers. As I said, I worked for a CEO that used to say, look, we're spending all of this every year. What are we getting for it? Lifestyle medicine is the way to go. And you can sort of look at why employers are interested in this. If $22,000, and this was actually last year for a family of 4, and what the costs have done over the past few years. It's pretty remarkable. And again, it has to come somewhere. When we made these engines, and every year, if we had an extra $30 million that we had to pay for health care, my CEO says, well, look, how do I pay for a $30 million increase in health care this year, every year? Do I put $30 million more on the cost of my engines to my customers? Or do I take it out of wages and other benefits? But the companies aren't going to absorb it. They're going to pass it on either to the customers or the employees have to pay for it. Almost 160 million people are covered by employers, predominantly large employers. Large employers are feeling the pain. Again, they control the benefits. So this is what I would say is the strategy. Part of what I do in the Institute is we look at how do we align strategy to move the needle. Blue zones, we know, is very powerful in terms of lifestyle medicine. Former president of the American College of Lifestyle Medicine. You've heard all these talks, these wonderful talks today. You know the power of lifestyle medicine. Policy, medicine, bringing those together. Employers can help you fund it. So this is how it works for employers. So employers, as I said, they pay for the bill. They set the policies. A patient sees a provider, and I don't like that word. I'm sorry that it's up here, but anyway, a physician. But a provider could also be a hospital. But so self-funded employers, they, one of their members sees a provider. Provider says it costs $100. They bill the insurance company. Insurance company pays the provider the $100. Minus some discount probably, but for the example, $100. So then what happens is that the employer turns around and bills the self-funded employer for $110. And what's happening here is that they want to recoup the $100 that they paid to the provider, and then they get a 10% administrative fee on top of that. And so you think, well, that's really not a premium. So large self-funded employers really are not paying premiums. They are at total risk for this. They might have a stop loss at a certain amount, but for the most part, and they reconcile these accounts on a monthly basis. So they'll pay out those claims, and they have like an escrow account that they pull the money they draw down from to do this. And what they get for that $10 administrative fee, they set up the network, they contract with you guys, they credential you guys, they make sure that the benefits are adjudicated, the claims, vendor management, customer service, and part of the customer service is to stand between the patient that has a complaint about a denial and the employer. Why is this not paid? Why was this denied? That's part of that $10. Data aggregation, reporting, so they get their $10. And again, I'm using hypothetical numbers, but this isn't far from the truth, but I want you to just sort of understand the situation here. So the administrative fees is really a percentage of claims. So you have your claims costs, which is in the blue, and then you have your administrative fees, which is that 10% that I mentioned. So now what happens if you reduce the spend by 50%, you also reduce the administrative fee by 50%. So is that health plan really going to be interested in reducing the costs? I don't think so. That's not good business. Now, they want to give it lip service. They want to make sure that the employer thinks that they're doing all that they can do, and we denied this and we denied that. But they're just tweaking the edges. They're not really getting to the root cause, which would be lifestyle medicine. So the employer has a lot of reasons to be involved, and it's not just the direct medical costs that we've been talking about, but there's productivity. So at Cummins, again, 55,000 employees. We had employees in Brazil, China, India. We still wanted these kinds of programs, even though it was a government-paid health plan in those countries. And the reason is because presenteeism, absenteeism, you can't offshore those things. If you have workers, then you have to contend with them. We had a plant in Indiana, one of the plants that I work closely with in Indiana, they had a float team. So we had, hundreds of employees in this plant, and every shift, we would bring in 21 employees that were cross-trained to replace those that would not show up. And so my deal selling a wellness program into that plant with the plant manager, and the plant managers are kind of like their own kingdoms, I said, what if I cut your float cost by 10%? I get rid of 2 of them. And you only have to now pay for 19. I'm all ears. So anyway, those are the kinds of things they can't offshore. It's a bigger value proposition than just healthcare costs. You have people that need to retire, but they can't retire. All of those issues are things that employers are concerned about. And they're the only entity that really, has a horse in this race or a dog in this fight, whatever metaphor you want to use. And they've done several of these studies that show, and we did the same thing. We showed that as you increase the lifestyle medicine, we called it the Lifestyle Medicine Index, which was basically metabolic syndrome. And as you saw that increase based on your health risk assessments, costs went down, and we could do it by plant. And we would almost set up competitions among the plant managers to say, how healthy are you keeping your employees? But healthier employees actually lead to more productivity. I was just on a call a few minutes ago before I came up here, and we're doing this for some other companies as well. So you want to check the box. Employers can do that. They can manage all of these things better if they're actually using lifestyle medicine and they stay within the mix. I'm not going to spend time on this. You guys have been hearing what lifestyle medicine is, but it's the proper balance of these things that leads to optimal health. It's not a guarantee that you'll never have an illness, just like we were talking about in the cancer lecture a few minutes ago, but you can certainly decrease or minimize the risk of these things. And the analogy that I often use is if you're growing a plant in your backyard or your garden, and if you give it the right amount of water, the right amount of sunshine, and the right soil, you get a healthy plant. There's less chance that it will succumb to certain pests and insects, right? It'll be healthy, right? There's, you still may have to do some spraying or something, but your chances go down. Now, if you only do one of those things, just give it sunlight without any water, you know what's going to happen. You're going to burn up your plants, or give it too much of something and not something else. Well, the human organism's the same way. And if you do these things in the right balance, you get a healthy organism. And there's less chance that you're going to need all of these other things that modern medicine can provide, because you start off with just healthier protoplasm, just like with the plant. And so that's the power of this, and it's those things in the right balance and a therapeutic dose. That's the other thing. It has to be in the right dose. And all of us know that if you gave 1 milligram aspirin for somebody that has a backache, you're not going to get much benefit from that. It's not because the aspirin doesn't work. It's because you didn't give it in a therapeutic dose. So we also have to think about that when it comes to lifestyle medicine. Again, it's not something that's foreign to what we do. It's part of all the guidelines. I show this up as an example. This was from a while back. It was 2013, but lifestyle was said to be the foundation even back then, but it only got a page versus all the medications and things you're going to provide in the guidelines. It's part of evidence-based, but it doesn't reimburse, hence the topic today. This is a study I did at Vanderbilt University, 25,000 employees. This was a subset. It was a pilot study. We did a lifestyle medicine program. And 24% of the participants were able to eliminate one or more of their medications. And if you look at the real results here, this was on a group of type 2 diabetics, you can look at the type 2 diabetics that were in this program versus those that were not in the program versus the overall health plan costs. And you can see that year over year, we were saving a tremendous amount of money. We looked at Q1 and versus Q2 because we were a high deductible plan. And so people were still burning through their high cost deductibles before it would hit our ledger. But you can see the benefit there as it was going up. And the other thing that I want you to notice here is that our savings really came from specialty drugs. And that may not be obvious as you look at this, because if you look at the pharmaceutical side of this versus the medical, it looks like the medical actually saved more. And that's because specialty drugs are not on the pharmacy benefit side, they're on the medical benefit side. So when you look at these data, you have to keep in mind where these things fall in terms of the benefit design. But that's how we save money, and that's how we got this ROI so quickly. When I worked at Cummins, we built a 60-provider, 28,000 square foot facility, lifestyle medicine facility, and this is one of the things the patients would see. Would you like to stop taking your medications? It's possible, not guaranteed, but it's possible. See a lifestyle medicine provider, doctor to do that. And we were written up in Fortune magazine back then as really being cutting edge along these lines. We had a teaching kitchen that was part of this, and we paid for the teaching kitchen as a part of our type 2 diabetes management program. So it's just part of our protocol. And that's the other thing I want to say is that what we're doing here is we have to make this a standard of care. And how do standards of care usually come about? One is that you have to have physicians that want to make the change. You know, some people say, well, can't the employers just, mandate lifestyle medicine? Well, they could, but they don't have any real information on why they would do that. I mean, they could talk to a few of us, but if you think about laparoscopic surgery, was it the employers who said we want more laparoscopic surgery? No, it was us. It was the clinicians saying, look, this is a better way to do it. There's this faster recovery, there's less chance of infection. So we need to do the same thing around lifestyle medicine, but there also has to be a financial incentive for doing that as well. So again, bringing this all together in terms of what strategies need to look like. This is, again, what we do at the Institute. Policy is such an important piece of this. So a couple of things that we're looking at is that the future payment structures in medicine, we think we need to bifurcate how we pay for acute disease versus chronic disease. I think for acute disease, fee-for-service is fine. I break my leg skiing at Park City or wherever, then fee-for-service is fine. But when we talk about chronic conditions, then we need to pay for that differently, probably through a capitated system, but it has to have the right incentives as well. We talk about food as medicine. One of the things we're working on here is that if you think of food as medicine, how do we pay for medications? They're usually on a formulary, and they're tiered, so that you have your first tier with your generics, and you have your second tier with your single source brands, then you have your multi-source brands, and you have your specialty tier. But if you look at food as medicine, and here I'm just using a whole food plant-based diet as the example, and you compare it to a medication, and if your primary outcome is hypercholesterolemia, I've ranked them both as being very effective. But there's secondary outcomes that you don't get from the medication that you get from the food. We know that many people are food insecure, and so providing this food not only as a medication, but you're also helping them with their food insecurity. We know that a whole food plant-based diet is high in fiber, so a secondary outcome is controlling glucose. Secondary outcome is controlling your risk for colon cancer. It has no adverse drug effects unless there's an allergy. And then sustainability, I rank them the same. And then if you draw a least regressions line across the dots in terms of the value, you can see which one produces the most value. And if this is truly the case, and we know that it is, then why wouldn't we pay for it, just as we would a medication? So that's the conversations we're starting to have. And guess what? The self-funded employers are showing some interest because they would like to do some things like this, but you have to make this part of the benefit design. You just can't have it as a side, a side thing. So again, this is a typical formulary design. The dollars sort of show how much you would have to pay as the member as you go through those tiers. Preferred specialty drugs are a percentage, non-preferred or even a higher percentage. They usually have an out-of-pocket max, anywhere from $2,000 to $3,000. You can purchase a lot of food for that. Food as medicine would probably go in a first tier. The other thing that we're doing is that we're looking at a lifestyle medicine-focused practice, really looking at this in terms of a new sort of value-based model. And this is using food as medicine, but in the construct of physicians that have expertise in lifestyle medicine. And because there aren't enough lifestyle medicine physicians generally to support large employers that have a national footprint, there needs to be a virtual model of this as well. And so you see this as a center of excellence, and with recurring payments. I'll kind of walk through that in a second. So we're piloting this. We're going to probably start enrolling in the first quarter of this year, and we will have our first clients in first quarter of 2024. We have some large employers that are wanting to do this pilot. We'll have about 1,500 in the pilot initially. If anyone's interested, see me afterward. I'll be happy to tell you how you may get involved if you're really interested. But this is the way it would work, and they would get patients that have some of these high-cost diseases, and they would have those individuals for a 3-month period. They'd be paid on a PM. Again, this is the capitated model for people that have these chronic conditions. They would have those patients for about 3 months. This is not in lieu of the primary care physician. This is strictly a referral, center of excellence model. And they get milestone incentives. And what's important to know about these incentives, because usually incentives are what? 3 to 5, maybe 10% of your overall reimbursement for taking care of a patient. This is just the opposite. You can actually make more on the incentives than you get in the bundle. The bundle is there to keep you whole. The incentives are to be an incentive. And so what happens here, you get milestone payments. You can see them at 3, 6, and 12 months. Lifestyle Medicine Index, as I said, this is metabolic syndrome, more or less. And have you moved the needle on those? And if you have, then you get an incentive payment. Now, you have to move the needle without increasing medication. I see your question.
So, is this patients coming into physicians for office visits, or is this a kind of facility type thing where patients are fed and de-stressed and massaged, and what are you talking about here in your model?
Yeah. So it's a good question. So the bundle payments are to do all the above based on what the physician believes the patient needs. So it could even include some food, right? But not every patient may need food, but some might. Not every patient, and it includes health coaches, it includes RDs, right? Depending on what the patient needs, and that's between the patient and the physician. We give you the bundle. You decide what you want to do with it and how you want to use it, because the goal is you want to get to the incentives. It's not so much what's happening in the bundle, it's what you do with the bundle so that you can get the incentives. As I said, you get paid more for the incentives than you do for what you do in the bundle.
I would hope that we would look at more of outcomes, because I have a chronic patient, my daughter, that has, POTS and pericarditis, chronic pericarditis, and all these things, immune issues, and I'm looking for that facility where I can go have her learn how to cook good food and eat, and enjoy yoga and try to get her behavior, because from my experience, most of these chronic patients need 3 months of lifestyle changing actually. But what you're talking about is seeing a physician and working on some of these lifestyle changes.
Yeah, we're on the same page. You're absolutely right. It's seeing the physician. The physician is the captain of the ship, but the physician's working with a team. You know, just like a physiatrist has PTs and OTs and those kinds of things. It's the same model. And so we really wanted to borrow from what's existing, but put it in a lifestyle frame. And as they go through those 3 months, it's all about sustainability. So there's a teaching element along the way here. And I would imagine most physicians perhaps are not doing that actual day-to-day teaching, but the coaches are, to get that person on a sustainable path so that now, after the 3 months are over, you have the sustainability, and hold on, you'll see how that's paid for in a second. So you got to do you move the needle on the biometrics and on the labs, and you have to do that without increasing the amount of medications you're using, because we really want to see those things move based on lifestyle, right? So you just didn't double the statins or whatever to lower the cholesterol. You're actually doing this from a lifestyle. And now then the second bonus, and this comes at 3 months and 12 months, is medication reduction. So the first one, as long as you didn't increase the medications, you get that. The second one, if you want to get the second one, you actually have to show a decrease in medications, which should also make sense because healthy people shouldn't need as many medications. And this is what we showed at Vanderbilt, where you saw that 24% decrease in medications. And by the way, many of those medications, even though it was on a type 2 diabetic population, many of those medications were the Humiras and some of those inflammatory things, because we're putting people on an anti-inflammatory diet. And so those can be substantial savings. And then the last is, for a certain percentage, that you're able to actually reverse the disease or put it in remission. I don't want to get into semantics, but whether it's, remission or reversal, you tell me. If I get a person from a BMI from 30 to 25, is that reversal or is that remission? You tell me, right? I would say it's reversal, because I'm not going to say that that person is 25 is still obese. But yet when we talk about diabetics and we get them off the insulin and the metformin, we say that it's remission, it's not in reversal. But anyway, whatever you want to call it, you get the largest incentive for that. And guess what? You get that in the first year, but if they're also in remission in the second year, you get another bonus payment. That goes to your sustainability. Now, the average type 2 diabetic, I don't know if I have that slide, but it's about $12,000 a year for the employer. What percentage of that do you think should go back to that team that now allows that employer to save $12,000 delta between their type 2 diabetics and their non-type 2 diabetics? That's the point of negotiation. I would say at least a third, if not more, in both the first year and the second year. Now you're talking real dollars, right? So anyway, there's another question here. Go ahead.
I was just going to comment. My mother-in-law was able to get off insulin with weight loss and walking, and she feels like a new person. So beyond the payments, like once they get into it, some of that continues just because they feel so much better.
That's absolutely right. That's absolutely right. So I mentioned Vanderbilt. We had 4 years where we entered a vegan chili into the chili cook-off, the annual chili cook-off. 3 out of the 4 years, it was the best chili. It won. The first year didn't win, we suspect, because we called it a vegan chili. How stupid can you be? The next year we called it Mary Jane's and Mary Ann's, and then it was cool. And then once they figured out there was no meat, it was too late. They had already given it, but it was the best. But to your point, if that's the best tasting chili, why would you ever go away from that? And it's healthy. So that gets to the sustainability, and that's what we're looking for, and that's what we're doing. It takes some creativity, but if the incentives are in line, then we move in that direction. Another question.
Yeah, you mentioned that the rising costs, the biggest rise in healthcare costs now and in the future is specialty medications. How do you define a specialty medication?
That's a good question. So if you look at the PBM contracts, they define it. It used to be that it had to have certain storage, it had to be administered by, a clinician, et cetera, et cetera. Not anymore. Yeah, PO drugs that, and it just depends on where the PBM wants to place it.
I mean, in my mind, when I think of a specialty medication, I'm thinking of a lot of these monoclonal antibodies, Humiras, the Rituxans, the Emgalides, all these medications that, in my mind, when I think about it, they're treating conditions that probably are not going to be changed a ton with lifestyle. I mean, does that make sense? You're like somebody with RA, you're not going to take them, and by making them be vegan, you're not going to take them to, you're not going to change the course of the disease a ton.
Yeah.
With their lifestyle.
Well, yes and no. So I mentioned the Vanderbilt study. So we got people off the Humiras. We got people off of some of those TNF alpha inhibitors, which are very expensive. Yeah, I mean, maybe some of them you don't, but there's certainly some that you can. And the ones that are most common are some of the ones that are possible to move the needle on. So the other thing, though, is that if you look at the pipeline for most of these pharmaceutical companies, a lot of the drugs for type 2 diabetes are now considered to be, or they're at least priced as some of these specialty drugs. And everyone's sort of focusing on the specialty drugs because that's kind of where the money is. Yeah, you're right. You're not going to save a lot if you just get people off of Lasix or whatever. But if you can really put people on an anti-inflammatory diet, there's something here that we can track. So anyway, we're going to do a pilot, and we'll see. We'll prove it.
So theoretically, if we say this all takes place, what's going to keep the drug companies to look at their profits and their costs and saying, hey, we're down this year, let's raise the costs?
Yeah, I mean, they're doing that anyway. They're doing that anyway. I was just on a P&T committee just this afternoon. I sit on a P&T committee for employers, and we were looking at a drug that's increased, it has doubled its price in the last 4 years. And it's just a high-class steroid. So they're doing it anyway. And you're right, they probably will take price hikes. But the antidote to that is if fewer people need the drugs, you're still going to come out better. It's better than me trying to negotiate a 10% discount on a $90,000 drug if they don't have to take the drug at all. So, yeah. But they are smart. They'll try to get around it. But what I'm trying to create here is I'm trying to create an advantage for the physicians. If you get someone off of that, you should be paid. You should have the right incentives. And this is a better way to practice medicine. I think many of us are tired of being on the hamster wheel, the 10-minute visits, and you give them 2 drugs today, 4 drugs tomorrow, versus getting them off of those drugs or maintaining, a level of health and actually being paid for that, versus trying to figure out what CPT code I can bill for next. Did I get the patient healthy? Is their life better? That's what we went to school for. And some of these things can help us get closer to that. Question?
One last question, I'm sorry.
No, it's fine.
Really get into this because I think it's very important, and thank you so much for presenting on this. On your pilot program, I assume you're a physician and you're going to be having this stuff and kind of monitoring. So please do me a favor, and I'm a consultant, and I try to make you more money every single day. Track all of your expenses. Track every hour that you guys work. Because I do a lot of provider negotiations for value-based contracts and the incentives. And with them is how much profit and how much margin do you want to have, and make sure that everybody is paid.
That's
Because
right.
what we're seeing is not that.
I know.
And in fact, when we go through and negotiate a contract, it's like, well, this is what it costs us to do the medicine, not will you take $100. It costs us $125 to treat your patient. Medicine has to go. So please track your costs.
Please give me your information at the end. We'll do that.
So have you gone international? Have you been under other healthcare systems?
Yes.
And how does that work? I mean, you know, you go to Switzerland and rules are different. You can negotiate with healthcare, with pharmaceuticals. You've got a single payer.
So we pay a lot more here for just about everything than they do in other countries. The only two countries where you can advertise drugs directly to consumers is New Zealand and the United States. Other countries, they are not allowed to advertise directly to consumers, and consumers drive some of this. They come into the office saying they want this medication or that medication. You know how it works. Billions of dollars are spent on those advertisements. So, and also the government has different programs set up where they actually look at results. So you've seen the big debacle with the new Alzheimer's drug, how it kind of like slipped through under the radar. Well, they really look at this a little closer than we do here in the United States. There's something called PDUFA, where the pharmaceutical companies actually pay the FDA to rule on the drugs. So it's a very incestuous relationship there, and most people don't even understand that. So the people that are paying the folks at the FDA are actually the pharmaceutical companies that they're supposed to be watching over. Things like that have to change, right? And that's how you get those kind of debacles. But that's not happening in other countries. Other countries have not figured it out in terms of lifestyle medicine. Well, they're starting to. There is a lifestyle medicine movement in most of the major countries. In fact, in the Philippines just last year, lifestyle medicine was recognized as an official specialty within the Philippines. So in some ways, some of these countries are actually a little bit ahead of us, but they're starting to see that as well. What I will tell you is that in a lot of these countries that I used to contract with for Cummins, India, for example, the healthcare costs were really quite low, and it's pretty much government. I won't say it was the best. And so what we would do is we would go in and we would buy supplemental insurance for our employees, not just the employees, but the whole family. But what we were starting to notice over time is that the prices were starting to increase as we paid. So we were trying to figure out, is there a way for us to pay the employee so it was more indirect? Because as soon as they knew a big U.S. company was going to start paying for this, they jacked up the prices. So there are some of those issues. We haven't figured out everything yet, but I will tell you it was a very different system. Some good, some bad. It's not all good. Yeah. Same thing with Canada. We know it's not all good, right? Waiting lines and things like that. So, yeah.
Hi, I think in one of your earlier slides you listed Alzheimer's as a lifestyle-related disease. I was under the impression that we didn't yet know the cause of Alzheimer's. Can you comment on that, please?
Sure, I'm happy to. And in fact, on Sunday I'm going to be at I'm presenting with Dr. Shurney, the team on brain health, on Alzheimer's disease. And what we find is that there are those genes, the APO4 and some of those genes that are associated with it. But it's like, and we had a presentation earlier about epigenetics. Lifestyle can mitigate the risk that most people have, even if you have a genetic predisposition, considerably. And again, they have these drugs, but none of them are really a home run. But lifestyle, exercise, the proper sleep, how you manage your stress, proper diet, can really reduce your risk. Just like if you don't smoke, it can reduce your risk. And so that's what we're talking about. They did studies with identical twins. It was a Hawaiian study with identical twins. And they looked at muscle mass in the legs, thigh muscle mass. And those that had a higher muscle mass had lower rates of Alzheimer's disease versus their twin that did not, living in a different environment. So those are some of the things that cause us to believe that lifestyle is so important. So anyway, yeah. There's a really good book on that, by the way, by the Sure's Eyes, if you're interested in that, I can get you that too. And it's based on all their research. Yeah. Other questions?
Big, run.
How are we for time? I don't want to lie. Okay.
Okay, long-term thinking here, right? Like, this sounds really innovative and interesting and exciting. I work for Intermountain, we've got our liberal centers, trying to do this. I also work for arm of Intermountain that does our value-based plans. And one of the big frustrations from clinics as we visit is, okay, I've got your plan, I've got this payer's plan, I've got this payer's plan. Like, and we know that it sounds like employee-based plans, I mean, this is a huge percentage of our patients, but we also have all of our patients that are on Medicare, Medicaid, uninsured. I mean, is your long-term plan like, let's show this works and maybe convince others to go this direction? What's your end game here?
So the way that we envision this is we start with the large employers. And by the way, you really only need about 6 or 7 large employers. I mean, if you think about General Motors, General Electric, I mean, some of these large employers, there's this fear of being left behind, right? When I was at the Blues, Kmart would say, well, what did GM do? Well, if it's good enough for GM, then we want the same benefits. So you need a few large marquee employers to do this and show the results in the data. That will then start to move the needle. As you saw, it's about 160 million lives. About half the population is covered through an employer. So you start to move that needle, then the evidence becomes so irrefutable that now CMS has to take a look at it, because now this has become embedded and a part of a standard of care of how we do stuff. And now we can move the needle into Medicare, Medicaid, and those kinds of things. And some of the Medicaid plans actually might take it faster. So that's the plan. But you got to show results, and you're not going to get there by knocking on CMS' door or Congress's door. That's just not. So I think a faster way as an employer is you don't have to sell all of them again. You just have to get a critical mass to start moving the needle.
Dr. Shurney, that was incredible. I think we need to have you back maybe after your pilot study.
Absolutely, I'll be
I'd love
happy
to.
to.
hear the result of this. And unfortunately, I don't think the majority of our society got to hear this.
Well, I know. It's always the case.
Exactly. But I think Dr. Drollinger hit on what I would say was my last question. This was all employer-based.
Yes.
I was thinking, when I saw the title of your talk, I was thinking even more innovative, 30 years from now, 50 years from now, when health insurance doesn't come through an employer. But it sounds like, with the answer you gave, is at some point we'll be there, right? If you can prove this.
I think so, yeah. So this is a short-term strategy to get to a long-term goal. So, all right, thank you.